Hey, Doctor. How you doing? You okay?
Yep, wonderful. Great to be here.
Great. So today we're joined by Dr. Julien Freitag, CEO and CMO of Magellan Stem Cells. Just so I don't butcher the introduction, do you mind giving us just a brief introduction to yourself, your background, and then we'll kind of go into it?
Excellent. So I'm a musculoskeletal physician, sports and exercise specialist. My primary practice has been involved in, degenerative musculoskeletal conditions, including osteoarthritis and tendinopathy, and that's led me on that research sort of endeavour into the role of biologicals in active treatment, in the active management, and hopefully cure of these conditions.
Okay. And then today we're going to be talking about some of your research and like what's been going on, especially like knee osteoarthritis and stem cells, how it all works, just to clarify a lot of the questions that a lot of people have as well.
Perfect.
So I think a good place to start would be some of the trials and kind of trips that you've been doing. Is it mainly focused on like stem cells and knee osteoarthritis or other conditions that you're kind of looking at?
I'm quite fortunate to have an affiliation with Magellan Stem Cells over the time course of close to 13 years now. Magellan Stem Cells have been around in early stage preclinical research over 17 years ago and then developed into clinical translational therapies. The focus has been on musculoskeletal. I think the luxury of that is that biologics, cell-based therapy, stem cell therapy has reproducible evidence in musculoskeletal medicine, and that's been our primary focus. So particularly on degenerative musculoskeletal medicine in areas of unmet clinical need like osteoarthritis.
Yeah. So it's like a big area. And typically, because everyone's doing different things and there's a lot of questions around this, are you folks focusing on like using autologous cells, so person's own cells, or are you using like donor cells or umbilical cord derived cells? Like what's the focus for you folks?
I guess there's a consideration, and this is perhaps a journey of my clinical practice. And initially when pursuing biological therapies, I used and still use things like platelet-rich plasma, which I find to be a very useful adjunct in regards to pain and functional improvement in symptomatic arthritis and tendinopathy. What we do see, however, with these interventions is the structural benefit is limited, the longevity of the success is limited. So that led my research into the area of cell therapy. Many years ago, we were very fortunate in regards to the regulatory environment within Australia, whereby there was a TGA exemption to cell-based therapy, so using you to treat you in the autologous setting.
Mm-hmm.
And so that's allowed us to translate research from the preclinical research. Magellan's research history was in canine veterinary research, but that research and proof of concept we were able to translate under that clinical exemption to do autologous treatment in Australia. What we actually found through that was very reproducible benefit, but we also found that some stem cells are very active and some stem cells are a little bit sluggish. So in the allogeneic setting, in the donor stem cell setting, we can actually take a very active, very potent stem cell to get greater reproducibility in the treatment of osteoarthritis. So definitely that off-the-shelf concept makes it far more accessible for the broader public.
Yeah. And then when you say from the donor, is that from other healthy humans, not from any other sources? Is that what kind of you're focusing on?
Yeah, correct. So we take from a healthy donor. We take particularly from a donor very strict requirements in regards to donor tissue procurement, both nationally and internationally. So that's very important for health safety standards. The other consideration is choosing a cell line which has a high potency for the treatment of osteoarthritis. So it's a very selective process, and it's been probably the course of our research over the last 12 years in clinical research has been really developing a selection criteria to pick the appropriate cell for high potency in osteoarthritis.
Yeah. And this is a question we get quite often because a lot of people are quite elderly. Is one of the reasons is does the potency in someone's own cells go down or as they age? And that's probably one of the reasons as well.
Look, I think it's really interesting that because there's a consideration in research that as we age, our stem cells age and perhaps they're a little bit more sluggish when we age. But when we've done retrospective subgroup analysis on our own patients who we treated in the autologous setting using you to treat you, eldest patient at 92 has done just as well as our youngest patient at 18. So in regards to the clinical outcome, we haven't seen that. We've seen older patients do particularly well with their own stem cells. What we see in the donor stem cell environment, however, is perhaps a young, healthy stem cell you can mass produce to much greater numbers. And so that allows us to create from, say, one donor harvest upwards of 1 million doses, whereas if we take an older donor, we may not be able to get as many doses from them.
Okay. And then that leads me, that's quite interesting actually. And then so this also leads me to another question, because there's a lot of confusion between like treatments where cells are like minimally manipulated or they're like isolated and expanding. It sounds like you
Correct.
folks are doing like the isolation and the expansion. Just for a lot of people out there, can you kind of explain the difference between like minimally manipulated autologous stem cell treatment as opposed to an isolated and expanded stem cell treatment?
So I think across the regions that the concept of minimally manipulated does vary a little bit. I know, say that 10 times quickly. But needless to say, actually, minimally manipulated tends to be a same-day process. It tends to mean that you're not adding anything to it, that you're not changing that tissue. At best, what you tend to get with that is a mixed cell population. It's definitely, it gets that confusion because it's under the regenerative medicine banner. It's even brought in under the stem cell banner. But essentially, it's a very mixed cell population, and many of those preparations have less than 0.01% mesenchymal stem cells. What we see from research in that area with the minimally manipulated processes is sometimes we actually see reasonable clinical efficacy, but we typically don't see longevity and we typically don't see any evidence of disease modification. Definitely the reproducible clinical efficacy, the longevity, and the evidence of disease modification is in more the isolated expanded cell populations and cell treatments, which we do in our own research.
Yeah, because I think that's a super common, as in different countries will have to. There's loads of different opinions on that, and so I think it's important for people to be aware.
Absolutely. In Australia, the consideration is homologous use. Homologous means taking a tissue and giving back to that same tissue. So if you take, say, abdominal fat is a rich source of mesenchymal stem cells, but if you're taking cells from abdominal fat and injecting them into the knee, that's non-homologous use. And yet other countries will accept that if it's going into an area where we do find fat, then that is homologous use. So there's not an agreement amongst regions in regards to terminology and definitions sometimes.
And that's the confusion for a lot of people.
Yes.
And then again, so you mentioned the nutrients there, stem cells are coming from either the fat tissue, the abdomen area, or like bone marrow quite often. For you folks, because you just mentioned there fat into fat and bone into bone, are you guys taking cells from bone marrow for knee osteoarthritis, or are you kind of mixing?
Yeah, so I guess we were quite fortunate at the beginning. The consideration for us is what it was in the autologous setting, what is the easiest area to harvest?
Yeah.
What is the least invasive area to harvest? And that typically is abdominal fat. Doing a small liposuction procedure where you're taking anywhere between 20 to 40 grams of tummy fat, and then doing an isolation expansion process. Fat actually is a rich source of mesenchymal stem cells. It has anywhere between 1 to 10% mesenchymal stem cells. Marrow can have as low as 0.01% mesenchymal stem cells. So whilst it's accepted or considered to be a rich source of stem cells, in regards to mesenchymal stem cells, which we use in musculoskeletal medicine, it is a very poor area. So you do actually have to concentrate bone marrow samples. You do have to potentially do a much more arduous isolation expansion process if using bone marrow. So fat was the easiest source. It's also been shown that it's probably the best cell source in regards to high expansion of cells. So that's been fortunate for us. And the clinical research has shown fairly reproducibly that fat-derived stem cells tend to be the most efficacious in musculoskeletal medicine.
I was just going to ask you that. Is there a difference in efficacy between the bone marrow and the fat? And from your research, you're saying that.
It's really interesting because the source varies between research. And I think if you look broadly, and this is where we look at the research and the level of research and the quality of the research, and we definitely need to do far more randomized controlled trials in this area. We definitely need to use randomized controlled trials with larger patient populations as well to show reproducibility. But if you do take those randomized controlled trials and the ones which have been well designed, you do see adipose tissue tends to be more consistent in regards to pain and functional efficacy and disease modification. Is bone marrow does actually get very good results as well. Unfortunately, there's not a lot of evidence in umbilical cord mesenchymal stem cells, and the only small studies initially have not shown to be highly efficacious. So definitely more research is needed. It may be that we just need to be doing more research in umbilical cord in the clinical setting, and that may show that it's got good efficacy, but at present it's very limited.
Yeah. And I think this is what's, when everyone's talking about the umbilical cord, and there's always like this, maybe it's mass marketing, but there's always like a preference from patients because they want to use like the umbilical cells because their own cells are not as potent. That seems to be like the approach for a lot of people. Um, what, if people are looking at like the umbilical cord cell treatment, are there any like major risks you think they should take into consideration, or lack of research? I guess you have any thoughts on that?
Look, I think the consideration for an umbilical cord, it's the youngest adult-derived stem cell that we can really source, and therefore it must be the most potent. Maybe it's the most underdeveloped adult stem cell, and therefore it's less relevant for musculoskeletal conditions. We don't really know. I think there is a lot, you're absolutely correct, there's a lot out in that space, a lot of comments made which are not backed by rigorous research and science. Umbilical cord obviously is that donor cell line, so it doesn't require a harvest. So there is that ease of consideration of patients getting treatment in regards to they just have to present for treatment rather than having to do a harvest procedure and wait 6 to 8 weeks for their cell therapy to be developed. So there's an ease consideration, but with donor tissue, there's really strong requirements internationally in regards to ensuring that that donor tissue is safe for use. So that level of safety and quality control, I think as a patient, you have to be very considerate about what measures are being taken, what measures are being enforced. So you definitely have to ask the right question of providers.
Yeah, in terms of where they're getting it from. And
where they're getting it from, how they tested, how do they test for viability, safety, what research has been done, what's been published. I think the consideration is, many proponents rely on other publications and other research. And when you look at cell-based therapy, the method of preparation can be exceptionally different. So for one group to say, we're doing stem cell therapy because of these positive publications, if they're not using the same method of manufacture of preparation, they don't have the same product. Therefore, they can't lay claim to those outcome results. So patients definitely need to be educated. I think this platform has a really great opportunity to educate patients to sort of say, ask the right questions, make sure you're pursuing safe treatment. That's the number one priority, and treatment which has a level of evidence of efficacy.
And you mentioned something interesting there. You mentioned in terms of viability and that's thrown around by a lot of clinics, and for patients as well. When you say viability when it comes to stem cell treatments, what do you mean by that?
Well, definitely if you're storing stem cells, and we typically store stem cells and they're a live cell in cryopreservation, because live cells at ambient room temperature, don't last a long time. The consideration is then how are they stored, how are they cryopreserved, how are they brought out of cryopreservation, and what percentage of cells are viable at the end of that process. Are you injecting a significant live cell population? Are you injecting cells which are on the way out, or a significantly high population of dead cells? So I think that quality control is very important, and I think patients should be asking for that quality control.
And obviously, if the cells are on the way out, or they're dead, or they're not actually alive, that then affects the quality of the result that they're getting. Ultimately.
Absolutely. And I think that's the consideration of where cell therapy has been potentially of significant benefit in research. A lot of other treatments, compound-based treatments, or other biological treatments, they're injected, the treatment happens, and then it's gone. So it's a very singular effect. You get retention of stem cells, not forever, but for a period of time. Therefore, you can get this ongoing treatment effect, not not simply relating to just that first injection. So having a live cell count, having a particular dosage is pretty relevant in regards to the long-term efficacy of that treatment.
And it works. And how are, again, this is interesting for me to ask as well. Like, how are the cells actually working? Are, in terms of your research and what you've seen with MRI imaging after, the cells differentiating into cartilage cells? Is it more of a paracrine effect? How are they actually working in the joints?
So look, historically, and you're saying all the right terms there with paracrine effect and differentiation. So look, historically, we've always felt that stem cells have an ability in that regenerative medicine space because they can differentiate. Mesenchymal stem cells are what we call multipotent. They can differentiate into different cell lines along what we call the mesodermal lineage, and that particularly is more musculoskeletal type tissue, so cartilage, bone, muscle, and fat. So we expected that was how they are going to actually disease modify, to improve arthritis, to regrow cartilage. However, there's not a significant amount of evidence that actually occurs. The more recent evidence is that they work by a paracrine effect. I like to think of mesenchymal stem cells as a bit of a project manager. When they are injected into a joint, they're really assessing the local environment. They're looking at what's out of balance and they're looking to balance it. So if they see a very inflammatory environment, they will push out anti-inflammatory factors to just balance the environment. And that often leads to pain and functional improvement and creates a healthier environment for the existing cartilage. The other thing which they will also see is if they see cartilage which is struggling, cartilage which is a bit quiet, it's not producing, the cartilage cells aren't producing a lot of cartilage, they will upregulate the local environment. They'll upregulate those local cartilage cells to express more collagen. So therefore we will see some aspect of regeneration. It's not because they themselves became cartilage, it's because they stimulated the local environment to upregulate and produce more cartilage.
Yeah, I think that was confusion because if you look at our websites, it talks about that. When you look at the actual research and researchers' thoughts on the trials, it kind of
Absolutely.
says something different. And that's what we were finding. Like when we're actually looking at the papers and the research, it says one thing, but then you go on every single website and it says, hey, they're turning into these cells and this is what's actually.
Yeah, and I think this is where patients do have to ask the right questions. And there's an enormous amount of very good information online. But there's a lot of misinformation as well. So you do have to try and sift through what's relevant, what is more advertising material versus what is more factual. I think the importance for me as a clinician working in the regenerative medicine space and in stem cell therapy is really being able to give patients a very balanced understanding of expectation and what may or may not be achieved. For me, what we see in our research is we see considerable pain and functional benefit, and we often see that retained for many years after a single treatment. What we tend to see very reproducibly is stabilization of the arthritis, reduction in the progression of the osteoarthritis. So arthritis is a progressive condition which gets worse every year. If we can stabilize it, prevent its progression, and improve pain and function, arguably how long's a piece of string in regards to will we delay, defer, or prevent knee replacement? Am I going to produce a brand new knee after stem cell therapy? Absolutely not. We may actually get really robust regeneration after a singular trauma if we treat in that acute or subacute phase, and we've seen that in our research. But in a chronic long-term condition like osteoarthritis, we're stabilizing the structure and we're improving pain and function, and that's our endpoint.
And see, is what you're seeing is realistically only one treatment is needed. Someone doesn't need to have 2, 3, or they don't need to come back every 12, 18 months.
It's an interesting, it's not like a pharmaceutical model where you come back once a month for your script.
Yeah.
So our first patient in our research is now close to 13 years post-treatment, still symptomatically dramatically improved. Now they had end-stage grade 4 bone-on-bone arthritis. As a clinician, that's striking for me. Case studies like that tell me that regenerative medicine, stem cell therapy has a real place in modern management of osteoarthritis. Now, there are some patients in our case series who, represented around 8 years or 10 years, and they had some recurrence of pain. And we've got a small case series now of patients who have had repeat treatment, but this is years on.
Yeah.
So the longevity of this process is really exciting. What we don't know yet is those repeat treatments, do they do just as well as the initial treatments? Does 10 years become 20 years, become 30 years? Can you make that string as long as you want.
Yeah.
So that's really interesting. But the other balance we find is that stem cells don't work for everyone. It's a bit like a blood pressure medication, which works for one individual but doesn't work for another individual. We see upwards of 85% success in stem cell therapy using our technique in mild to moderate knee arthritis. That does drop to 75% if you have severe knee arthritis. It's still a very good response rate, but there's 25% in grade 4 bone-on-bone who don't get an appropriate response in regards to pain and function. In regards to level of pain relief, we have upwards of a 70% improvement in pain on an average for our mild to moderate arthritis. And if we're treating severe arthritis, which often comes with greater pain and more functional limitation, we have a 50% improvement. So for me, it's ensuring that patients understand what they may achieve with treatment, not thinking that this is a panacea, that this is going to cure everything. This is an incredibly good management tool, and it has an incredible amount of, potential in medicine if we understand it and we use it correctly.
And why do you think, is it, I guess there might be ideas, and why it's different for different, are there any factors that indicate it may be better for someone else or not? Is it down to genetics, makeup, where they're from potentially? What are the kind of ideas behind that?
Yeah, you're absolutely right. Look, as a sports physician, musculoskeletal physician, I thought I was really lucky. Osteoarthritis, it's relatively simple, but when you really dig deep,
Yeah.
osteoarthritis is an incredibly, complex condition. It's not just a singular condition. It's not just wear and tear. The pathobiology now of osteoarthritis and our understanding of what influences osteoarthritis and that degeneration, it's an enormity of factors and influencing factors. It can come down to biomechanics, it can come down to environment, it can come down to race, it can come down whether your osteoarthritis is very inflammatory in nature or degenerative in nature. So it's a very complex condition, and those variables all have impact in regards to whether you have success. Now, that said, the benefit we have is we're not treating osteoarthritis with a singular compound which works on a singular pathway.
Mm-hmm.
So say you have different types of osteoarthritis, you've got a cell which can respond to the environment and go down different paths of action to achieve a balancing response, to achieve a pain and functional benefit. So you've got a very malleable cell which can adapt to the environment, and therefore that does create a relative consistency of outcome.
Yeah. And so are you saying, is it better to get the treatment earlier on the earlier signs when you recognize, like, for example, if I've got early signs of osteoarthritis right now, is it better for me to get it looked at now rather than wait 10 years till it gets like to grade 3 or grade 4, for example?
Yeah, look, I think that's a very good question to consider. And I do believe that with increasing evidence, that's perhaps the pathway we will pursue. It'll be more preventative medicine. It'll be early diagnosis, early treatment, therefore retention in function, prevention of development of pain and dysfunction. And I do believe that that's probably where cell-based therapy is going to go for many degenerative conditions. And that's purely because we do tend to see greater improvement, greater structural benefit in the earlier onset than the severe. And it really is going to just take time for us to develop that research and that understanding. But I do believe preventative medicine, much like in most areas, is going to be the right approach.
Where it's going to go. Because I've seen when injuries and you let them fester and get them lie, they can get worse and worse. And then to try and
Absolutely.
change it, like,
Absolutely. And particularly with stem cells, and in our own research, what we have seen is because one aspect of osteoarthritis is what we call secondary or post-traumatic. So you have a traumatic injury and that later develops into progressive osteoarthritis. What we've seen in patients in our case series is if we treat that traumatic injury, we get a marked healing regenerative response such that they do not progress onto osteoarthritis. They actually have a very robust regenerative response and near complete healing response.
yeah. Oh, and then, okay, so sorry, I've digressed as well. If we go back to the work with Magellan, the trials you folks are on, have you folks, is it the most recent one been a phase 2? Have you recently done the phase 2 trial? Is that the most recent one? that you focus?
Yeah, so the most recent one we completed was a phase 1/2A study on our allogeneic preparation, our proprietary cell line called MAG200. So that was a phase 1 safety. It was what we call an ascending dose study. We started at a low dose. We then, as we show safety, we go to the next dose. And we're really wanting to see whether we can see a dose response curve as well. What is the most efficacious dose? So in that same safety study, we then followed those patients out to 12 months for efficacy markers in both pain and function and structure. From that, which was a very successful trial, the therapy was well tolerated, very safe. We were able to see both a low and high dose, which was very efficacious in both pain and function. There was a trend that the high dose was more efficacious in regards to disease modification and prevention of progression of osteoarthritis or improvement in cartilage volume. So we're now on the footsteps of actually commencing our phase 3, our pivotal phase 3 trial. Which will be to show reproducible evidence that MAG200 is suitable for the treatment of osteoarthritis. And that trial will support registration, hopefully, in both Australia and international regions.
International regions as well. Okay. So potentially people are looking, can they come from other countries into Australia, or is there a difficulty because you may have to do the follow-ups and they may have to come back and forth?
Yeah, unfortunately for the study, it's Australian based only because of the level of follow-ups and face-to-face visits over the time course of 12 months post-treatment. It really is only for Australian residents. Now, that said, we would be looking to have fairly efficient recruitment. We hope to be actually putting in registration for both registration in Australian and international regions in late 2028. This is an area of unmet clinical need. So most regulators have an expedited fast-track approval pathway for unmet clinical needs or areas of unmet clinical need, of which osteoarthritis is one. There's a real understanding internationally that we need to find a different, therapy as opposed to simple pain relief and joint replacement surgery.
I think that's what most people are looking at. Some people come to say we don't want to get the replaced knee. Sometimes their doctors are telling them like you could do it, but we wouldn't recommend you doing it. Or they've had it a couple of times, there've been infections. I think that's one thing a lot of people try and put off surgery and trying to do something different.
I think it's really important because it's a consideration of what are we going to achieve from surgery. Upwards of 30% of patients are unhappy with their results in regards to total knee replacement at 12 months. They have persistent pain and loss of function. You've got close to a 2 to 3% serious complication rate with major joint replacement. It's got a 0.6% mortality rate associated with it. So it has relevance. Absolutely. There are some patients who require joint replacement surgery, but if you've got a minimally invasive conservative intervention, which may delay or prevent the need for joint replacement surgery, I think the world's really looking to hopefully see success in these trials because it's needed. There's a really interesting figure which basically shows that even if knee replacement was a really successful operation, a very safe and successful operation, we don't have the workforce internationally to actually do the knee replacements which are required. We're doing an increasing number of knee replacements. Close to a third of knee replacements are performed on patients under the age of 65. Young patients, and these joint replacements only have a finite lifespan. So it's a really dangerous area where we're moving towards, and we need a real therapy which can considerably delay or prevent that need of major surgery.
I mean, you mentioned non-invasive. The actual treatment itself, is it painful? How much time do people have to take off? What does that knee kind of stem cells like treatment what's it look like?
I think for me, I really break down my treatment for osteoarthritis into measures of what we need to do. And the conservative measures, we still need to focus on. We need to focus on good weight management. Simple pain relief can be effective. Regular exercise is a cornerstone of treatment of osteoarthritis. It's really taking away that fear that some people have in regards to exercise because they think they're going to be damaging their joint, as opposed to exercise being joint protective, which we know it is. Yes, I don't want them to be playing rugby league, but I do want them to be doing good balanced exercise and regular exercise. In regards to, treatment and stem cell therapy, it is an adjunct. You have to do the conservative measures, you have to maximize your outcome, and then you do stem cell therapy as an additive adjunct therapy. It is relatively straightforward as an allogeneic donor cell preparation. It is literally off the shelf. And so it's a single intra-articular injection, so an injection into your joint. Common side effects with stem cell therapy, and this has been noted in most studies which have done joint injections with mesenchymal stem cells, is a self-limiting period where your knee does experience some discomfort, often some degree of swelling and discomfort, which will settle within 1 to 2 weeks with the use of simple pain relief and ice. That's a really commonly seen in trials, but it typically is a very well tolerated treatment. In regards to, if we look broadly across research using mesenchymal stem cell therapy in both intravenous and intra-articular applications, we don't see any evidence of serious adverse events. So it is accepted, adult stem cell therapy is accepted as a safe therapy when done well with good quality control.
And so no risk of tumors and cancers or anything like that?
Yeah, we've learned very quickly about, I guess, the type of cell we want. Embryonic stem cells are great for research. They're great for research in the laboratory, but they're not great in regards to clinical research because they can grow into anything. They're what we call pluripotent. They can go into any cell line, and they can grow into anything. Adult-derived mesenchymal stem cells, they exist around our body already. We're just concentrating them in a particular area which needs them, and all the research based on that has shown excellent safety.
When you've kind of had people go through trials and treatments of like stem cells for knee osteoarthritis, what's like the actual recovery time? I know you mentioned there's some pain in the knee, and then what's the actual like recovery time where they can start seeing results and get back to like the activities they want to be doing?
So, look, what I typically advise patients is they need to have a quiet week after their stem cell injection. So it's not that they need to lie in bed and do nothing, but in regards to prescriptive exercise, they're having a week off, they're having a holiday. And for that reason, it's because when I see people get back to exercise too early, they can get a small delayed flare, and that can be quite uncomfortable. So typically after a week, if their pain has returned to pre-injection levels, I allow them to get back to their pre-injection activity, and then they can progress their activity as pain allows, as their functional improvement occurs. We see improvement as early as 4 weeks after an injection, but typically in most research we see the first real clear, statistically significant improvement at anywhere between the 1 to 3 month mark. So it's relatively quick after treatment. It's relatively an organic increase in activity levels and function. As they feel better, they do more. Obviously, as people feel better, I like them to then hopefully be able to progress with their exercise program, which will also additively improve their arthritis management.
And would you say, like, because I know you mentioned people, the first case study, grade 4 bone hormone, that's like insane, right? That's really, really bad. Would you say there's a bad candidate for this, or anyone that you'd say, you know what, maybe it will help for
Yeah,
this?
look, I think there's what I've seen over our time course, and this is where, but it is interesting. I've seen severe bone-on-bone arthritis with marked joint deformity do exceptionally well. And so it does sort of give you a consideration that if you have a really simple intervention which has an opportunity to do significantly well and delay or prevent a knee replacement, I think if it becomes accessible, and I'm talking cost accessible, but also reproducible efficacy and an appropriate product, then a simple intervention like that, I'd be putting my hand up, even if I had severe arthritis, before considering major surgical intervention. The thing which I think is very relevant is if people have significant mechanical symptoms. So they've got ligament deficiency and they have a grossly unstable knee, which collapses on them. No injection is going to provide stability. An injection will reduce inflammation, improve pain, and it may improve range of motion and function if that's relevant in regards to their inflammatory process. But if they've got a structurally unstable knee, no injection is going to repair that. And that's where, quite commonly I will advise patients whether they actually need surgical intervention.
Yeah. Yeah, it's interesting because people because they'll come with knee OA, but then there'll be other things that are meniscal damage or structural damage within the knee.
Absolutely. And so this does bring into line, currently with knee arthroscopy, we understand that if we do a knee arthroscopy and there's coexistent arthritis, we're actually going to accelerate people towards knee replacement threefold. So going in there and doing a cleanup is really not considered the right approach now. However, if someone's got a meniscus tear which is causing mechanical instability because it's unstable, sometimes we do have to do an arthroscopy. And that's where perhaps stem cell therapy is going to be very relevant. So if you have to do a knee arthroscopy to repair or do a partial resection of an unstable meniscus, you then treat the coexistent underlying arthritis later with mesenchymal stem cells. So I think a lot of these treatment modalities have the ability to work well together, and it may actually bring surgical management into consideration as well, whereas currently we're a bit cautious about knee arthroscopy because of that acceleration in arthritis.
And this is something, again, I should have asked earlier on, and extend because that's quite interesting in this conversation. Because we do have like a lot of people from Australia come to as well, and sometimes want to travel, but sometimes they don't when they learn about the regulations in different countries. Right now in Australia, stem cell treatments legal and available, or are there only very certain pathways that you can potentially get?
There's very certain pathways. So in the past, under the TGA exemption, we were able to treat you with you. That got reviewed in 2018, 2019. And since that time, the only access to stem cell therapy primarily has been under ethics-approved research protocols and programs. So we've had a very long-standing real-world evidence trial on the use of stem cell therapy. That's actually completed recruitment. The only access now to stem cell therapy in Australia and appropriate access would be under what we call either the authorised prescriber or the special access scheme. Special access scheme is for areas of unmet clinical need where you've maximised conservative management and patients are unsuitable for other considered interventions, whether that be due to health or age. And you're only able to use treatments which have good evidence of safety and clear developing evidence of efficacy. So it's primarily for Australian residents. So we can pursue stem cell therapy under the special access scheme when appropriate for Australian residents, but it's quite well regulated. The TGA in Australia is not obstructive. The TGA is really actually very encouraging in regards to completing research, and they've been very engaged with us in regards to ensuring that our phase 3 design will be well powered and well designed to hopefully support registration in Australia and beyond.
Yeah. So, like a normal clinic outside, it seems, cannot just say we're going to start offering these treatment, expanded, isolated mesenchymal stem cells to. You can't just walk into a clinic. Anyone can just do that in Australia.
No, in Australia, no. The regulations are there they are there to protect the patients. They're to ensure that, I guess, the manufacturing technique, the treatment is done ethically, that particularly if done within research, that patients are recruited ethically, that they've got a clear understanding of the treatment and the risks involved. So yes, it's definitely not a therapy which is available to everyone. It is available under the special access scheme for appropriate patients, but we have to be very clear in regards to working within those appropriate regulations.
And one more, I've asked you so many questions, and I know we've got to shoot, but one question I'm interested in is, why do you think there's so many differences of opinions or like controversies regarding stem cell therapy around the world? Like if you talk to someone a doctor in the UK, for example, most of them will say no, it's a myth, and you should never do. Like you talk about PRP, and people get confused. And I'm just in the UK, and that's not around the world. Why do you think there's so many difference of opinions and like controversies around like stem cell therapy, especially for orthopedic conditions?
I think there's a lot of confusion because of terminology. I think a lot of things get brought under the regenerative medicine banner. I think a lot of things get put under the stem cell banner inappropriately. And I see a number of patients who say, I have had stem cell therapy, and what they have had is platelet-rich plasma, which can be a very good biological cell-based therapy, but it's not stem cell therapy. And what we expect from PRP is very different to, say, what we expect from mesenchymal stem cell therapy, whether they're doing a same-day procedure or, an isolated expanded cell preparation, which is very different. There's an enormous amount of confusion out there. That does make it really complex for general clinicians and surgeons to try and decipher all the information out there and what's relevant, what's not relevant, what has efficacy, what doesn't have efficacy. So it's not clear for patients, and it's not clear for most clinicians. I think that's where the difficulty is. There is also, unfortunately, a big commercial drive in some practices, and therefore they're really looking at information which supports their dialogue,
Yeah.
and it may not be actually representative of what they do. I think patients have to ask the right questions. They have to have a platform like yours, which actually advises them on what questions to ask, where there are good regulations. So whether it might be tightly regulated, but that actually encourages or enforces safe treatment. As I said, the real priority at the start is to cause no harm. So having safe treatment, and then also showing that it's efficacious. I think it really does require the right questions to be asked and the right information to be out there. So your platform helps in that incredibly.
Yeah. Thanks. Appreciate it. And yeah, I think that's one of the things, especially with the commercial drive in a lot of countries that we've seen. But yeah, look, I know I've taken up your time. Really
Yeah.
appreciate it. You've answered everything. I think I've gone through a lot of topics and questions, so hopefully people will have a lot of a clearer
It's
understanding.
such an exciting area, Omar. It's such an exciting area. That's why I'm still here, many years on after I thought would be a few fun years of research. I'm going grey rather rapidly, but it's really exciting. This will change medicine. This will really change orthopedic medicine, musculoskeletal medicine around the world. It will have an enormous impact on the community in regards to quality of life. It's why you see countries like Australia, Japan, South Korea really investing in regenerative medicine and stem cell therapy. Japan has an aging population. We all have an aging population. We all have a significant amount of increasing degenerative conditions associated with reduction in quality of life. So we're really looking to, I guess regenerative medicine has always been thought about how can we live longer? But essentially what we're really now thinking about is how can we live better? So if we are going to live longer, do we really want to live that poorly, or do we want to live that life well, highly functioning? And so it's really about living better for longer.
Yeah, I think they hit the nail on the head. You can increase the lifespan. Okay, that's amazing. But what if that latter part of the lifespan is in poor quality?
Absolutely. And if you look at lifespan's been increasing exponentially from the 1950s. This is well before regenerative medicine. We're just treating conditions better, but unfortunately that means as we live longer, we have a much greater incidence of degenerative conditions. And so that's where stem cell therapy may have a significant role. And it really is an exciting time period. And I think around the corner, we will have registered products, which gives clinicians, I guess, certainty in regards to efficacy and safety, and this will have significant impact then on the broader community.
How long before you think this will, how long for approval, or do you think this will become more?
I think we've had a really good stepping, I guess, consideration in regards to biologicals which have come onto the market. Platelet-rich plasma has been around for 20 plus years. I've been using it, for close to 2 decades, and yet it's probably only become recently acceptable. Platelet-rich plasma as a biological, as a cell therapy, I think that's really paved the way for consideration and acceptance of other cell therapies like mesenchymal stem cell therapy. So no, we're really just around the corner. Essentially a completion of this phase 3, and we're not the only group who are in late stage cell therapy development. We are around the corner from having a disease modifying agent for osteoarthritis, which has never been and we don't currently have, and that will be readily accessible to the broader populations. We're not talking this is 10 years or 20 years away. For us, we're talking 2028, and that's a really exciting opportunity for people.
Yeah. Wow. Okay. Things are moving quickly.
Yeah, absolutely.
Okay. We might have you on in about a couple of years next year when it comes closer. But look, Doctor, really appreciate your time. Hopefully everyone's found it useful as well. And yeah, if any other questions, just give us a shout. Let us know.
Yeah. Absolutely. Please, Omar, if you have any questions from anyone who's listening, please pass them on.
100% will do. Thanks, Doctor.
Appreciate your time. Thank you.